Hey everybody, and welcome back to Amanda Marie NP, where on my channel I'm on a journey getting my NP and I want to help other students who are just like me. Today we're going to be talking about one of the most common reported sexually transmitted infections, and that is chlamydia. So when we think about chlamydia, it can be scary as a new NP, but don't worry, we are going to learn this together. There are a couple of takeaway points that I want to make sure that you have embedded in your brain when you click out of today's video. When you hear the word chlamydia, I want you to think friable cervix. But I don't want you to just think friable cervix. I want you to know what a friable cervix is. So when you do a pelvic exam, you're going to see a bright red cervix. It's going to be irritated looking, just kind of angry, and it's going to bleed easily. So we need to know that chlamydia is more common in women who are under the age of 25, and that they will have an abnormal vaginal discharge, sometimes a yellowish color, and a burning sensation upon urination. So those are the things that should come to your mind automatically when you think of chlamydia. Let's look at some case studies, because obviously we will be tested looking at case studies over and over again on boards. We need to be prepared on how to pull out the information, find out what's important and what is not. So let's talk about chlamydia. A 17-year-old girl comes into the office complaining of burning upon urination and some different looking discharge. She admits to having 2 recent sexual partners and not having used condoms. When doing her vaginal exam, you note a red cervix that bleeds very easily. What would you be suspecting? So you see here they didn't use the term friable cervix, but they described, because they wanted you to know that they were describing a friable cervix. So of course we are talking about chlamydia here. So next, when we talk about chlamydia, and this is its presentation, we need to know how to treat chlamydia. So would we A, use azithromycin, B, flagyl, C, penicillin, or D, over-the-counter monostat? Well, I hope you know that we would use A, azithromycin. That is our go-to treatment as of right now. Now, we also need to know what we would use as a backup if our patient had an allergy to macrolides and could not use azithromycin, and that would be doxy. Now, I also want to just let you know that at the very end of this presentation, there's some really good things that you can check out and click on, and every reference that I use for my information gathering for this presentation will also be linked at the very end of the description. Let's look at another case study. You're a nurse practitioner for a women's health clinic. You tell the 18-year-old patient that she's tested positive for chlamydia. She tells you that her friend had chlamydia once and told her that if you get chlamydia, you'll have a weird vaginal discharge. Therefore, she's questioning the results, saying she didn't have a weird discharge. What would be your best response to this patient? A, the lab must have switched the results. Let me run the test again. B, the majority of patients with chlamydia are asymptomatic. C, vaginal discharge is not actually a symptom of chlamydia. Or D, vaginal discharge only occurs when chlamydia progresses to pelvic inflammatory disease. So here they're wanting to make sure that you know the key points and takeaways as it pertains to chlamydia, which again is the most commonly reported and seen sexually transmitted infection in the United States. So the correct answer is B, which is that most patients who have chlamydia are asymptomatic. And that is one of the reasons why we test every pregnant mother for chlamydia, because she very well could be carrying this and not even know it. The majority of patients with chlamydia are asymptomatic, but if female patients do have symptoms, this is then where we're more likely to see that mucopurulent discharge as a result of cervicitis or inflammation of the cervix. So that is just a detailed rationale slide for you. So what test will be ordered to test for chlamydia? Again, this is just another basic knowledge that we have to know what test would we select if we saw these in a test question. So there are actually 3 different ones, but I want to make sure that you know that the nucleic acid amplification testing, or the NAAT, is our go-to testing for chlamydia. We can also do a gram stain, but it's not used as often anymore. And we could do a culture in a petri dish, but this takes about 5+ days to get the results back. And the NAAT is much more sensitive, specific, and we can get the results back quicker. How can we prevent chlamydia? And just as a side note, we all know that we're going to see questions on primary, secondary, and tertiary prevention. So a form of primary prevention is actually what we are talking about here, and that is the use of condoms to decrease the amount of direct contact a person has with an infected individual. So chlamydia can be spread not only by sexual intercourse, but also oral sex, as well as mother to child during delivery. So dental dams are used for oral sex prevention as well. And then lastly, childbirth. The way that we can prevent this being spread to baby would be to treat mom. And just again, noting here with the asterisk that chlamydia is the most common sexually transmitted infection in the world. So as we stated before, chlamydia is normally asymptomatic. And I bring this up again just to kind of pound away that. I want you to take away from this presentation that this is kind of one of those silent type of infections that a person could have and not even realize it. So we need to make sure that we are testing for this. Okay, let's do a true and false question. And that is, condom use is an ineffective method for preventing the spread of chlamydia. True or false? The answer is false. Barrier methods like condoms can prevent the spread of chlamydia. And if engaging in sexual activity or intercourse with a person who has known chlamydia infection, of course, abstinence is best. Which of the following is a risk associated with prolonged untreated chlamydia disease? This is, again, it's normally asymptomatic, so we need to make sure that we understand the adverse effects of having chlamydia for a long time and it not be treated. So would it be A, ectopic pregnancy, B, increased risk for contracting HIV, development of pelvic inflammatory disease, or D, all of the above? And the answer is D. All of the answers as complications of a chlamydia infection. Pelvic inflammatory disease might occur if a patient is left untreated. So every single one of those things are complications. And I also wanted to share with you guys some what I'm calling fun facts, just kind of FYIs, things that I think that you need to know. While chlamydia is most likely to be detected in women ages 16 to 20, trichomonas is more likely to be detected in ages 47 to 53. So think about that when you're reading your questions on the boards. If you're given an age, you want to know that the younger population of women are going to be more susceptible to it being a chlamydia versus an older woman is going to definitely be more of a trichomonas type thought process when answering questions. Now, I thought this was interesting. I found this one up to date, so I wanted to bring it to your attention. It says that single-dose azithromycin had previously been another preferred option, but based on mounting evidence that the microbial efficacy of doxy is superior. You can read the slide. The reason I included it is because if a person does not have gonorrhea, which a lot of times those two go hand in hand, chlamydia and gonorrhea, if you test and they're negative for gonorrhea, the research is actually showing that doxy is more superior for treatment. Now, I don't necessarily think that we're going to see a question where doxy and azithromycin are both available options to choose from. I really highly doubt we will, but I just want to draw your attention to the fact that if you're treating chlamydia alone and not chlamydia and gonorrhea, you might want to go ahead and check your source in your practice because it is really looking, according to UpToDate, as though doxy is your best choice. As I stated, chlamydia and gonococcal infections may coexist in a significant percentage of community patients. So all patients with chlamydia should also be tested for gonorrhea. Individuals of childbearing potential with chlamydial infection should undergo pregnancy testing, which we've talked about a couple times. And this is particularly important if treatment with doxy is planned, as we know that doxycycline is generally avoided during pregnancy. This is definitely not an antibiotic that we want to give to a pregnant patient. This is one of the resources that I think was absolutely amazing. I included a couple screenshots here for you for STI treatment guidelines and then the link. And then this is my list of references I used up to date, as well as the OSU website, and I included 2 really great detailed videos on chlamydia infection. I hope that this video helped you. I'm going to be making tons more videos just like this to help you prepare for your boards as I am preparing for mine. So go ahead, subscribe to the channel, become an NP with me. I'm just an average Jane doing my thing, and I would love for you to come along for the journey.